Hi, welcome back to my channel. For today's video, I'm going to share the things that you may need to know before working or starting in recovery, especially in the UK. So by the way, if you're new here, my name is Jet and I'm a recovery nurse. I used to work in the operating theater back in the Philippines as a scrub nurse, a circulating and a PACU nurse. But now in the UK, I've decided to move on and specialize with recovery. If you're new to this channel, you may consider liking and subscribing so you will get the updates whenever I post a new video. I share tips, experiences, and stories that I myself experienced in the UK while working here as a nurse. I'm originally from the Philippines and I've decided to come to the UK and stay here for good. For this video, I'm going to share the things that you may need to know before considering or working in recovery. Some of the following that I'm going to share in this video are some of the things that I myself did not know before choosing to specialize in recovery. So let's start with number one. In the UK, if you're going to work as a recovery nurse, you may not have a nursing assistant or a healthcare assistant to support you inside the recovery. We do have a porter who will assist us in pushing patients back to the ward or in a private suite. If you need support, you may need to depend on your fellow nurses or ODPs inside the recovery. This is because the patient-to-staff ratio in the UK is conveniently 1:1. There are times though that sometimes this ratio becomes 1:2, especially if, for example, in my trust, there are no available beds for one of the patients to go to. So in some instances, these patients have to stay inside the recovery for a little while longer. For our departmental protocol, patients have to stay 30 minutes in the recovery. We have to make sure that they are stable and they are fit for ward transfer. And considering that the patient had just come out of theater and still under the effects of anesthetics, there is a need for close monitoring and observation. Number two, because the patients are still under the effects of anesthetics, usually general anesthesia, a recovery nurse is expected to master his basic life support and ABCDE. Unlike in the concepts of resuscitation where compressions come first, inside the recovery, when you are doing your primary and secondary assessment, airway is always at the top. So always address the airway and breathing problems before you move on to the other problems, such as circulation, visibility, and exposure. You may also encounter scenarios where the patient comes in with a supraglottic airway, such as a laryngeal mask airway. So it's your job to remove the LMA once the patient is more conscious or once the patient has regained consciousness. It's also your job to ensure that the airway is patent and the patient is able to cough and swallow. So ABCDE skills are really crucial. If you are a new nurse working in recovery, you don't have to worry because you will undergo a lot of trainings before they will allow you to work independently. So in your first few days as a recovery nurse, you will be under the supervision of a more senior team member who will serve as your mentor. And as part of your training, you also need to get signed off of several competencies before they let you work individually. As for me, because currently we are understaffed, it took me 3 months to finish my competencies, which includes post-operative care, anesthetic agents, other medications, hypothermia management, shock, anaphylaxis, and also pediatric competencies. And third, because you work as part of the peri-anesthesia team and you have to be very familiar with the types of anesthetic agents that anesthetists use. And aside from that, you also have to know what are the effects and what is the duration of the effects of these agents. It is also helpful if you know how to reverse the effects in case your patient takes a little bit longer to recover from the anesthetic. So in my local trust, the general anesthetics that we use usually wears off within the first 5 to 15 minutes. So during this window, it is really crucial for you to monitor closely your patient. Sometimes they wake up confused, perhaps even aggressive. As a recovery nurse, you have to be ready and anticipate these types of scenarios, and you have to know how to respond to them properly. So knowing the effects of the anesthetics might help you prepare the necessary equipment or reversal agents needed for these types of scenarios. Also, don't worry if you haven't mastered or you haven't memorized these agents yet, because during the initial period, you will be guided with your mentor, and for patients who arrive in the recovery with supraglottic airway, it is part of our policy that at least 2 recovery practitioners should stay with the patient until the supraglottic airway is taken out. Fourth, being a new staff, it is also helpful if you familiarize yourself with the location of emergency airway equipment and emergency supplies. In my local trust, for example, each recovery bay has its own trolley, and each of our trolleys have several drawers, and each drawer contains specific types of supplies. And for example, on the first drawer are things that we use to maintain airway patency and deliver oxygen. The second drawer is composed of bandages, support dressings, and plasters. On the third drawer, we place there extra documents or extra paperwork in case we need additional pages in our documentation. And at the bottom drawer, we place ink pads, diapers, napkins, and things that we use to clean and dry the skin. Fifth thing that you may be happy to know is that in the UK, it's not a mortal sin, but actually it is encouraged to ask questions if you are unsure, if you don't know something. This is a very positive thing for someone like me who came from the Philippines, because in my culture, it is rather, there is a negative connotation if you ask questions too much. But in this country, it's the opposite. Actually, they want you to ask more questions whenever you are in doubt, especially when you are in doubt. So in this way, you could minimize potential errors and causing unnecessary harm or suffering to your patient. So if you start in recovery and you're just new, you have no theater background before, always ask questions before you do something, even if you've done it before. One thing that I appreciate from British practitioners is that they never get tired of you asking questions, and they actually like it when you do ask questions. Don't be shy. On a side note, ask questions appropriately. Be careful with your tone and your words. It's all a matter of etiquette. May it be in person or when talking to the phone, you have to ask courteously and politely. So if you want a polite and a courteous answer, be polite and courteous as well. 6. Just like in the ward, we store our controlled drugs in a cupboard inside the recovery area. In order to access the cupboard, you need the keys. And in my local trust, there usually is one person who holds the keys at any given time. It could be the charge nurse or anyone from the team. Before you administer a controlled drug, there has to be another practitioner, may it be a nurse or an ODP or anyone registered, such as an anesthetist, to second check the drug that you are giving. So the drug has to be checked with the prescription chart, and the second checker must ensure that you are giving the correct name of the drug, dosage, and especially the expiration date. We also second check saline or water that you use to dilute or flush the IV cannula. For oral drugs, for safety and practical reasons, we always have a second checker. This may not apply to all trusts. Number 7. Just like administering controlled drugs, it also is mandatory, in my local trust at least, to have another person, another registered practitioner, to witness that you are discarding any drug that is not administered. We have a logbook where we record every controlled drug that we administer to our patients. We record the name of the patient, the initials number, the date that the drug was given, the amount of drug that was prepared, administered, and discarded. And there are at least 2 people who should sign this entry. It would be unwise for you to discard the entire syringe after administering your morphine or fentanyl, for example, on the sharps bin without having another person check how much was left on the syringe. Number 8. This might not apply to all trusts, but in my local trust, we don't have regular graveyard shifts for recovery nurses or recovery practitioners. What we have instead are on-call shifts, and there's a high chance that you will have to report when you are on call. Based on what I've observed, it doesn't usually have to take the entire night or early morning for your on-call. Usually we could go home after 3 or 4 hours, and the pay is not that bad, but it could definitely get higher. Number 9. So in recovery practice, you have to know if your trust or your hospital uses a specific pathway for a certain type of surgery. For example, if the patient is undergoing a total hip replacement, Maybe your trust is using an enhanced recovery pathway for total hip replacement. So you have to familiarize yourself if they are using a specific form or a specific pathway. In my local trust, for example, we have pathways for orthopedic surgeries, for gynecological surgeries, pediatric surgeries, and other types of major surgeries. So again, if you are not sure, ask. Number 10. This is something that confused when I was starting as a recovery nurse. Here in my trust, we still document using written forms, using paper forms. So as a recovery nurse, you have to be familiar with the types of form and their arrangement within the patient's files. For example, my trust uses a separate chart for medications, which is the prescription chart, and another chart will be for fluids, another chart will be for blood transfusion, IV cannulation, Foley catheter, diabetes sliding scale, some drugs such as gentamicin. So as a recovery nurse, you have to make sure that all of these are present within your patient's file if applicable, and all of these are written off before you send your patient back to his room or back to his bay, back to his ward. These forms are also in addition to what we call our perioperative pathway, which is a single collection of files dedicated for the patient's surgery. So the perioperative pathway contains information from pre-assessment, anesthetic assessment, pre-op, intraoperative, and post-operative. And each of these documents are labeled with the patient's sticker containing his name, birth date, and NHS number. And the last tip or advice that I could give if you are working in a new environment such as recovery, you have to familiarize yourself with the different terms, nicknames, slangs that they use in practice, because this could help, especially if you come from a non-British hospital. They may call the drugs differently, they may have different brands for these drugs. So I will cover these terms that we use in recovery in a separate video to give you an idea on how much differences our way of calling things or saying things. So if you like this video, please click like and subscribe and watch out for that video. Thank you again for watching. My name is Chet, and see you on the next video. Bye bye.